minutes, 20 minutes, just brief, don't go on explaining better. An interactive chat box. Somebody is asking, please, I'll give the answer.
If interactive means we should challenge them.
No, if they are asking anything, I will let you know. Very good afternoon and a warm welcome to one and all to yet another edition of undergraduate clinics at Believers. This is a part of vertical integrated undergraduate virtual classes on Zoom platform from Believers Medical College, Pathanamthitta, Kerala. Okay, today's topic, as we all know, is November 14th and World Diabetes Day and also Children's Day. But obviously, you are not children, you are young adults, and so anyway, the World Diabetes Day marks the birthday of Frederick Banting, who along with Charles Best and John James Rickard McLeod were the first to discover insulin in 1922. The World Diabetes Day is a primary global awareness campaign focusing on diabetes mellitus and is held on 14th November every year. And it is by the International Diabetes Federation, IDF. And each World Diabetes Day focuses on a theme related to diabetes. This year it is nurses and diabetes, but here we always cover the syllabus related to diabetes. And today we are discussing all about the pancreas. So as for the usual classes, we request the students and attending faculty and esteemed audience to please make this class an interactive session by posting questions in the chat box and answering also in the chat box when a question is asked by the speaker. All your doubts will be cleared at the end of the session if the time permits. Okay, coming to today's academic session, it is pancreatic stones and the Malayali. So students, on your mark, get set, here we go. The first class is being taken by the Department of Team Bright, which will be followed by a presentation of the Department of Radiology. And the last session today is by your favorite Associate Professor of Surgery, Dr. Abraham Matthew Sir, who will be quickly asking you the rapid fire MCQs, all about the pancreas. And that would truly make today's academic session a real brainstorming extravaganza. So let's start. Coming to the first class, Pancreatic Stones in the Malayali by Dr. Sujit Philip. He is Senior Consultant, Gastrointestinal Surgeon of Believers Medical College, Tiruvalla. He did his MS and DCH in Gastrosurgery from Tirunelveli. He is a fellow of the Indian Association of Gastrointestinal Surgeons. His degree reads as MS, FMAS, FIAGES, DNB, MNAMS in Surgical Gastroenterology, and Jan Berman's Fellowship in Hepatobiliary Surgery and Liver Transplantation. Over to you, sir, for your presentation, Pancreatic Stones in the Malayali. Dr. Sujit Philip.
Good morning, everyone. Our topic today will be mainly on chronic pancreatitis. Pancreas is a very vast organ and we can't cover everything in one class. So I thought since today is World Diabetes Day, we thought we'll cover on chronic pancreatitis. Now, before we start the topic, first thing is I want to make a differentiating chronic pancreatitis from acute pancreatitis. What is it not? So acute pancreatitis, as the name indicates, it's just an acute inflammation of the pancreas. The whole of the pancreas gets inflamed. That is acute pancreatitis. Now, this is different from chronic pancreatitis. So, this is how an acute pancreatitis patient looks. He'll be in severe pain. Usually, it is epigastric, ready in the back, and the patient is in extremis. And then about 20% of acute pancreatitis patients will go to the ICU. So when a patient comes to the casualty with severe abdominal pain, the usual three differential diagnoses that goes to your mind are either ureteric colic, acute pancreatitis, or mesenteric ischemia. These are the three things which usually causes severe abdominal pain. So one DD is this acute pancreatitis, and so this is a small diagram on how acute pancreatitis goes. We diagnose it by seeing the elevation of amylase lipase. There'll be CT features of that, and it usually affects one part of the pancreas, either head, body, or tail, and there might be necrosis or there may be this duct disruption, etc. And how does acute pancreatitis occur? So this is the etiology given in Bailey and Lau. You can remember as BAPTRI, BAPTRI. B is biliary, A is alcoholic, P is postoperative, T is traumatic, R is rare, and I is idiopathic. So biliary means usually it is due to gallstones. And in a hospital, the department surgery and usually does around 500 cases per year, and about 30-40% cases are due to we do the surgery of laparoscopic cholecystectomy, that is the removal of the gallbladder for biliary pancreatitis. That is pancreatitis occurring due to gallstone. So that is one major reason. And the reason for acute pancreatitis in Kerala is alcohol. Now, the reason for taking this topic is some of you might be familiar with this textbook on the right side. That is the Bailey and Short Practice of Surgery, which the moderator and my colleagues and myself and all are studying for surgery. I don't know whether you need to study that. So in this internationally known textbook, there is only one mention of Kerala in this international textbook, and that is regarding chronic pancreatitis. Because in Kerala, there is a specific entity called tropical chronic pancreatitis. So tropical chronic pancreatitis means it usually occurs it has 4 features. That it usually occurs in young patients. These patients usually will be malnourished, they will have diabetes, and they will usually be from lower socioeconomic condition. So this is how tropical chronic pancreatitis occurs. So what is this? What are we saying when we deal with chronic pancreatitis? So let's see that. Chronic pancreatitis usually means stones in the pancreas. Usually occurs with stones or calcification in the pancreas. The whole of the pancreas is inflamed, and the pancreas duct will have multiple strictures and dilatations. And another important thing is chronic pancreatitis is irreversible compared with acute pancreatitis where it is reversible. So acute pancreatitis, once the episode is over, everything will get back to normal. But in chronic pancreatitis, it's not getting back to normal. The whole pancreas is inflamed and fibrosed. So tropical chronic pancreatitis, which I mentioned earlier, is a variant of, it's a type of chronic pancreatitis. So that usually occurs in Kerala. One reason it is thought that it is due to kappa or cassava, which contains cyan glycogens. And these are the features for tropical chronic pancreatitis. That is, might be due to malnutrition, increased ingestion of cyanogenic glycosides, that is kappa, and might be also be due to hydrocarbons released by kerosene and paraffin lamps. However, as we know that we have stopped using these lamps, us taking more carbohydrates, us taking this cassava has come down. So because of that, tropical chronic pancreatitis incidence has now come down, but it is still there. And every week we get 1 or 2 new patients with tropical chronic pancreatitis. That is younger patients with stones in the pancreas and abdominal pain. Now, this is how chronic pancreas looks like. The pancreas duct will be dilated, there will be strictures in the duct, there will be stones in the duct, and the pancreas many times is atrophic. Sometimes the pancreas won't be seen at all, it will be a huge big duct. And so this would be a good definition for chronic pancreatitis. That is an incurable chronic inflammatory condition, and it is usually multifactorial in its etiology, highly variable in its presentation, and it is a challenge to treat it successfully. I'll be coming to that towards the end. And it remains an enigmatic process of uncertain pathogenesis. So, what is the problem associated with this? So, as I said, there is progressive conversion. It's irreversible. So, there is a progressive conversion of pancreatic parenchyma to fibrous tissue. So, that is why it is becoming irreversible. And the peak presentation usually occurs when the person is at the prime of his life, that is 35 to 45 years of life. And what usually occurs, there are these things which occurs are, one is malnutrition or maldigestion. This is because pancreatic lipase and 3 things actually, trypsin lipase and the acidification of the alkalization of duodenum gets affected. So there is malabsorption. So that causes maldigestion. There can be diabetes, and there can be other associated complications. These problems usually occur with chronic pancreatitis. So let's go briefly into this. So etiology of chronic pancreatitis, we already seen one etiology of chronic pancreatitis, that is being a Keralite, that is the tropical chronic pancreatitis. So tropical chronic pancreatitis can be seen in other parts of the world also, and that includes parts of Southeast Asia, parts of South America. These are also there, but Kerala is a highly prone area. But the most common cause of chronic pancreatitis is alcohol. So another reason why it is so high, incidence so high, is because Kerala has the highest per capita income of alcohol consumption in India. Rarer reasons for chronic pancreatitis can be hereditary, hyperparathyroidism, and the long list which I put up. Compare this with acute pancreatitis. Acute pancreatitis reasons were BAP-TRI, biliary alcohol, post-operative operatic, rare and idiopathic. The etiology here is slightly different. And these are the different types of chronic pancreatitis which I will not be going into. And so pathogenesis, how does it usually occur? One would be the toxic metabolite theory, which I already said. It may be due to cyanogenic glycosides in cassava. It can be due to a burning out process of the pancreas. It can be due to oxidative stress hypothesis. So these are all hypotheses, and we don't know exactly what is causing chronic pancreatitis, but it has a significant genetic element also. The significant genetic element also, a SPINK mutation, that is also there. So this is how a patient with chronic pancreatitis would look. Usually has pain in the epigastrium, might be radiating in the back, and it might be continuous or intermittent. Now this way of sitting is called the pancreatic position. The patient will hold like this and sit forward. Sometimes they might sit forward in the tripod position. So when you go for rounds in the body, you might be able to see this. You might be able to recognize this patient with pancreatic pain because they will be bending forward. Because when they bend forward, that pain comes down because the stomach is getting, the stomach will move forward from the pancreas, so the pain comes down. Another important feature is steatorrhea. Steatorrhea means fat in stool. So this is how it looks like when there is, this is how the toilet will look when there is fat in the stools. This is because of malabsorption of fat. So we usually ask the patient, കൊഴുപ്പുള്ള ആഹാരം കഴിക്കുമ്പോഴത്തേക്ക് നോൺ വെജ് കഴിക്കുമ്പോഴത്തേക്ക് motion എണ്ണ പോലെ പോകാറുണ്ടോ. So that is one indication that the patient is having chronic pancreatitis. So this is one chart showing how chronic pancreatitis is different from acute pancreatitis. Acute pancreatitis is more common, chronic pancreatitis is less common, but they are completely different. And I'll go down. So the principal symptom of chronic pancreatitis വരുന്ന എല്ലാ പേഷ്യനും ഉണ്ടാകുന്ന major symptom is pain. If somebody asks you the symptom, it is pain, pain, and pain. So, what causes this pain? What causes the underlying pain, which is so difficult to manage in pancreatitis? So, these are the reasons. One would be the inflammation. Another is because of the stones in the pancreatic duct. The stones in pancreatic duct cause obstruction. There is pressure increase, and that will cause pain. Another is due to the fibrosis occurring. This fibrosis encases the sensory nerves, and that also causes neuropathy, and that causes pain. So tissue hypertension because of stones obstructing, fibrosis of the nerves affecting neuropathy. So these are the two reasons causing pain in chronic pancreatitis. There are two types of pain called type A and type B. Just know there are two different types of pain, and in our place, actually, type B is becoming more and more common. That it is chronic underlying pain. Type A is an intermittent type of pain. So malabsorption. Why does malabsorption occur in chronic pancreatitis? And that occurs due to these reasons. That is a lipase deficiency. It tends to manifest itself before insulin deficiency, and therefore fat doesn't get absorbed. Another thing is bicarbonate secretion to the duodenum is reduced, and which causes duodenal acidification and reduces the nutrient absorption. And as said earlier, one feature which is usually seen with chronic pancreatitis is diabetes, and diabetes occurs in around 20 to 30% of patients with chronic pancreatitis, and about 30 to 50% have impaired glucose tolerance. So malabsorption is one feature. Second would be diabetes, which I already explained. And one feature of diabetes in chronic pancreatitis is ketoacidosis and diabetic nephropathy are relatively uncommon. And retinopathy and neuropathy are more when there is diabetes associated with the chronic pancreatitis. And what investigations would you do? Usually there will be a long list of investigations, but practically what we do is amylase lipase. We get an ultrasound done. The ultrasound is not indicating the patient's symptoms are typical. We get a CT done. Usually with the amylase lipase in the CT, we'll be able to pick up the diagnosis. Another test we can do is an endoscopic. Another feature we can do is an endoscopic ultrasound, which is available here. I'll be coming to that now. So what are the investigations? Usually amylase lipase, then you ultrasound, CT, and if necessary, an endoscopic ultrasound. And what are the complications of chronic pancreatitis? Complications can be what the pseudocysts, other would be an inflammatory mass in the outer pancreas, can be malignancy, and there can be extra pancreatic complications. We'll be dealing that towards the end. I'll be dealing with shortly. Now coming to the treatment. So how would you treat this patient with the chronic pancreatitis? Treatment can be either medical or surgical. Now, medical can be, you can divide into medicines alone or endoscopic. So, what are the medicines you will give? The medicines you give. So, this is a cut paste from Bailey. How to treat the chronic pancreatitis. So, first is usually these. If it is due to alcohol, we have to treat the addiction of the patient, treat the patient's addiction. Second would be to alleviate the abdominal pain. The abdominal pain, how do you alleviate? Use increased analgesics in a step-by fashion. You initially would give us something like paracetamol, then you slowly escalate to propranolol and morphine as and when required. Third would be nutritional and pharmacological measures. So that would include diet. Diet would include a low-fat, high-protein diet. So we'll ask him to reduce fried and fatty food in diet. Second would be pancreatic enzyme supplements. Pancreatic enzyme supplements. It's called PERT, P-E-R-T, pancreatic enzyme replacement therapy, pancreatic enzyme supplements. Other would be correction of fat-soluble vitamins, micronutrient therapy. Steroids we use only in a specific type of chronic pancreatitis called autoimmune pancreatitis. And the next would be medium chain triglycerides, because when these patients have severe fat malabsorption, then a way of treating malabsorption is, other than giving enzyme supplements, you can give them medium chain triglycerides. There are brands available with the medium chain triglycerides. So medium chain triglycerides, the importance is that they usually get absorbed. They usually get absorbed from the small bowel. They usually from the mid small bowel, and you don't need enzymes for that. And of course, treat diabetes mellitus. So this is how you medically treat chronic pancreatitis. Treat the addiction, alleviate abdominal pain, nutrition, pharmacological measures, and then treat diabetes mellitus. So these are the medicines usually used to treat medically. And the brands usually available are multiple brands for this pancreatic enzyme therapy. And they are rather expensive. You usually would ask them to take Triside and try to reduce it as time goes by. So for this pancreatic enzyme supplement therapy or PERT, it's taken along with the usually taken along with the diet, and for pain we use conventional enzyme therapy, and we have enteric coated preparation also, because the problem is when the conventional enzymes are taken into the stomach, the gastric acid deactivates it. So prevent that, we have enteric coated preparation of this enzyme replacement therapy, and that is usually the choice when the patient has steatorrhea. So when the pain is the main symptom, then we give conventional enzyme replacement therapy. When steatorrhea is more of a symptom, then we give enzyme replacement therapy. And the endoscopic management is easy to imagine. What would you do? Like? So what is the reason for the pain? One reason for the pain is the stones obstructing the pancreatic duct. So you need to clear out the pancreatic duct. So that you can do endoscopically by doing an ERCP and clearing out the pancreatic stones and putting in a duct. Other way of doing it is you can also break up the stones by giving ESW. And I just show you some pictures of that. So this is how you do an endoscope. You do pass an endoscope down into the ampulla flator, and you cannulate the pancreatic duct and clear out the stones and put in a duct. So this is how it would look. This what is here is actually the ampulla flator. This is a duct in the pancreatic. This is a stent in the pancreatic duct. This is how an ESW will be done for pancreatic stones. This is done less commonly, very rarely, because nowadays we have endoscopes which have ESWL at the tip, so you can go directly into the pancreatic duct and you can crush the stones. And another way of treating chronic pancreatitis, because as I said, the 90% of cases, the main symptom would be pain. So to relieve the pain, you can do with an endoscopic ultrasound, you can inject alcohol directly into the celiac plexus. So this is where the celiac plexus will be. So it is through the celiac plexus that the pain starts. So you can inject through the endoscopic ultrasound, you can inject alcohol into the celiac plexus and that will relieve the pain. We have endoscopic ultrasound here. So that is one way of treating the pain. And so I just summarize what you said now. To treat it, you can treat it medically by enzyme supplement therapy. You can treat it by endoscopic maneuvers, ERCP, you can clear out the duct. You can treat it by endoscopic celiac plexus, US cardiac celiac plexus. So these are different ways of treating it. Now we come to the main method of treatment, that is surgery, because many times endoscopy is very difficult to do in chronic pancreatitis. Since the stones are stuck densely, it might be difficult to remove it. So practically what is done is, if it is not being treated adequately by medical condition, that is by giving pancreatic enzyme supplements, by giving micronutrients, by giving analgesics, if the patient is not getting control, then you would go for surgery. So surgery is, the indications for surgery would be this, that is pain, which is common indication. Then when there is a mass in the head of the pancreas, chronic pancreatitis can produce a mass in the head of pancreas and you suspicion of malignancy. Then it can cause biliary obstruction. How does it cause biliary obstruction? Because we know that the common bile duct passes through the head of the pancreas. So when there is an inflammation of the pancreas, the bile duct might get obstructed. Same way, the duodenum, as we know, the pancreas is inside that C loop of duodenum. So when the pancreas gets inflamed, the duodenum can also get obstructed. So that is another problem that can occur with chronic pancreatitis, that is duodenal stenosis. Then there can occur a rupture of the duct of the pancreatic duct, and that can cause balloon-like pseudocyst. That would be another indication. And there can be pancreatic fistula, and there can be vascular problems, like there can be thrombosis of splenic vein. Because of this multiple episode of inflammation, the vein can get thrombosed. So these would be the indications for surgery. Common indication of surgery in chronic pancreatitis will be pain. Others are mass of suspicion of malignancy, biliary obstruction, duodenal stenosis, pseudocyst, internal pancreatic fistula, and vascular problems. These are the 7 indications for surgery in chronic pancreatitis. So what types of surgery can we do? One is sphincteroplasty, which is rarely done nowadays. You can remember as drainage, resection, or a combination of this. So this is what is sphincteroplasty. That is a ampulla fiber is cut out and is sutured widely so that all the pancreatic juice can flow out well. It's done rarely nowadays, and it's done only when there is a large stricture in the ampulla fiber. What we need to remember as medical students are these points. Surgery can be resection, drainage, or a combination. Resection surgery would be Whipple. A drainage combination usually would be Fraze or an LPJ or lateral pancreatic aneurysm, and combination would be called a Bejer. So I'll just explain briefly what it is so you can remember. So as I said, a problem with the chronic pancreatitis would be presence of a mass in the head of pancreas. An inflammatory mass can occur in the head of the pancreas. It occurs in about 10 to 20% of, it occurs in about 5 to 10% of chronic pancreatitis. And there can be malignancy in that mass. So that is a problem. So when you have a mass in the head of the pancreas along with the chronic pancreatitis, you would do a procedure called a Whipple's procedure. It's a big procedure lasting around about 68 hours. And these parts marked in gray will be removed. That is pancreas head, duodenum, part of the bile duct and stomach will be removed. So that is what is done and it is reconstructed. So that is Whipple and that is a resectional procedure. More commonly, so this is what I meant. There can be inflammatory mass in the head of the pancreas and there can be a malignancy in that 10 to 20% chance of malignancy. This is the more commonly done procedure. What we do is we just open up the duct of the pancreas in a sideways manner, clear out all the stones and stitch a loop of the jejunum there, and that is called a lateral pancreatic jejunostomy. Now, along with that, so this was done by a person called, initially done by a person called Partington and Roche people. Now, what is known is that the main part causing pain in pancreas is the head of the pancreas. So, unless you address the head of the pancreas, pain is not going to come down. So, a person called Charles Frey said, not only will we drain out the pancreatic duct, we'll also core out or curate out the head of the pancreas also. That is called head coring. So, this is what Frey's done. Along with doing that pancreatic duodenostomy, he also cored out the head of the pancreas, and that's called the head of the. That's called the head coring plus lateral pancreatic duodenostomy, and the procedure is called Frey's procedure. So, even if you don't remember anything, remember this procedure, Frey's procedure. That is the most common procedure done for chronic pancreatitis. And this is a procedure called Becher procedure from Germany. So this is a combination of both resection and drainage. The resection procedure is Whipple, drainage procedure is lateral pancreatic duodenostomy and Frey's, and the combination of both is Becher procedure. And what are the complications that can occur with chronic pancreatitis? As I already said, since the common pancreas pass through the end of the pancreas, there can be biliary obstruction. And already mentioned, since the pancreas is here, the duodenum can get stenosis and can be gastric outlet obstruction or duodenal stenosis. And thirdly, because the pancreatic duct is getting disrupted, the fluid collections can occur, and that is called a pseudocyst. So that's in brief about chronic pancreatitis. So what did you hear till now? So if you're not listening properly, or you have some net connections, or your mind is disrupted, just quickly go through in 2 minutes of what did I hear till now. So this is what you heard till now. That is, yes, acute pancreatitis is reversible. Unlike that, chronic pancreatitis is irreversible. This is due to fibrosis. Then chronic pancreatitis has stones in the pancreas, and that's a common. And the chronic pancreatitis or a tropical chronic pancreatitis is one common thing which is found in Malayalis, and maybe due to eating cassava. Then we saw about the etiology of acute pancreatitis and chronic pancreatitis. Acute pancreatitis, I mentioned the pneumonia, BAP-TRI. Chronic pancreatitis, usually it is alcohol, and then you have rarer causes, including genetic. And Kerala, I already mentioned, most common symptom of chronic pancreatitis is pain. Then we have problems due to the complications like biliary obstruction, duodenal stenosis, and pseudocysts. And treatment of chronic pancreatitis is medical, endoscopic, and surgical. Medical, I already mentioned, pancreatic enzyme replacement therapy, analgesics, micronutrients. Endoscopic would be ERCP, US ciliary block. Surgery, I already mentioned, RICE, and that is drainage, resection, and combination. And one important thing to know is malignancy does occur in chronic pancreatitis. Why I keep on mentioning is somehow in Kerala, the chance of malignancy in chronic pancreatitis is found to be higher. In international journals, it's 10%, but in studies in Kerala, it's found to be 30%. So if there's any suspicion of malignancy in chronic pancreatitis, one would do a Whipple. So that's all about chronic pancreatitis. I hope it's been useful. God bless.
Thank you, sir. Thank you, sir. That was indeed a fantastic presentation. So I think Dr. Sujit, it was a fantastic presentation of a large topic. So it is very common in Malayalis, probably because of eating kappa, that is cassava. We don't know it is that or it is a hereditary tendency towards pancreatitis. We are not sure. So welcoming once again all of you for the second presentation in undergraduate clinics, that is imaging of the pancreas by our dynamic assistant professor in radiology, that is Dr. Danny Jose Titus. He did his MBBS from NG Medical College, Nepal, and MD in radiodiagnosis from VKMC, Tamil Nadu. He is currently working in capacity of assistant professor in Department of Radiology. So we request the students and attending faculty once again to make this an interactive session if he is asking any questions. So Dr. Danny, we are honored to have you to start your lecture. So indeed all of us like physicians, pediatricians, gynecologists, all of us cannot live without you, radiologists. Thank you. Please start.
Good morning, everyone. Like Elizabeth ma'am recognized me as a dynamic person. That's quite a compliment. I'll be talking about imaging in chronic pancreatitis. I'll try to make this topic as interesting as possible, since it's mostly a PG topic. To start with, let's remind ourselves what is the definition. Chronic pancreatitis represents a continuing inflammatory disease of the pancreas, which is characterized by irreversible morphology and functional changes. We have heard what Dr. Sujit has told, what are the causes, etiology of chronic pancreatitis, what are types of chronic pancreatitis. I'll be not going into that. I'll be directly jumping into the imaging section of the chronic pancreatitis. To start with, let's see how does a normal abdominal X-ray looks like, so that you will get an idea. And this is for all the batches who are attending today's class, especially. This is a normal abdominal X-ray, and it's a supine X-ray. And in this, we are just looking at the bowel loops, lucency, and the vertebral bodies and all. As you can see, there is nothing. There is no calcification in this shadow. There's no calcific shadows on where the pointer is being pointed. Okay, if you see a calcific shadow, that's a pathology which you have to think about. So that is what we're going to look in chronic pancreatitis right now. So abdominal X-ray for chronic pancreatitis is an obsolete tool. We do not do it nowadays. So why we do it, why am I explaining this to you is because as a spotter in surgery, practical exam, you'll be having a spotter on this X-ray. So what do you see is exactly, you see a multifocal calcification across the spine along the course of the pancreas. So remember your anatomy. Pancreas is a retroperitoneal organ. It lies horizontal, anterior to the spine and the retroperitoneal vessels, that is aorta and the IVC. So this is an X-ray of abdominal X-ray in which I'm trying to demonstrate the calcification of the chronic pancreatitis, which is lying on both the sides of the spine, as well as it's lying across the spine. This is a typical X-ray of chronic pancreatitis. So in a whole class, just remember this X-ray, because this will be in your exam during your surgery practical exams. Again, this is also a pancreatic calcification which I'm demonstrating on either side of the spine, across the spine. Now, coming to day our life, we always, the clinician asks to rule out chronic pancreatitis, and the most common investigation which we do day to day is ultrasound. So why do we do ultrasound? Because it's cheap, it's easily available, and it is non-ionizing radiation. I won't be talking about non-ionizing radiation. Most of you will be knowing what's the difference between ionizing and non-ionizing. So what do we require? What does a clinician require from us? And what do we require from a clinician when they send this case? So we have this pre-request. When we are asked to do evaluation for pancreas, our pre-request is that to the patient is that they should come in fasting state, as well as so that we can visualize the whole of pancreas. And we will be also asking the patient to drink water, so that we can distend the stomach and visualize the whole of the pancreas clearly. So again, showing you a basic of ultrasound image of how the pancreas looks. In either side, you can see the ultrasound image. The center is the color plate. In the color plate, you can see clearly how the pancreas lies. And you can see the transducer probe focused on the epigastric region. So on my left side, you can see the pancreas clearly, where the pointer is pointing out is uncinate process, the head, the body, and the tail. And the darker area, the black area, which I'm pointing out, is the vessel. The vessel which is coming here is the splenic vessel, and the portal vein and splenic vein. So this is what I was trying to demonstrate here. They are demonstrating the head, the tail, and the body region. So I'll be repeatedly telling the same findings in all the three imaging modalities. It's just the appearance today. So what are the ultrasound findings in chronic pancreatitis? This is inhomogeneity of the pancreatic parenchyma. That is the initial changes. These are the two important findings. That is atrophy of the pancreatic parenchyma. And thirdly, there is a pancreatic main duct dilatation with congregations. What Sujit sir was telling, in congregations means calculi. So they all, we can see clearly visualize this in chronic pancreatitis. So the early changes of chronic pancreatitis is quite difficult to be diagnosed in ultrasound. But calcification can be seen, as well as atrophy. We can clearly visualize that. What are other important things about other important complications which we can see, or pathology which we can visualize in ultrasound are pseudocysts, We can see thrombosis or splenoportal axis, and also we can see pseudoaneurysms, so splenic artery and gastroduodenal artery. So again, coming to the pathological slides, ultrasound images, you can see this is the pancreas on the left-hand image, the left-hand corner. We can see that the pancreas, you can see white foci. Can you see where the arrows are pointing out? Where I'm pointing out this white, and you look at the right-hand side of the image. This is where all I'm pointing out, this white dots. These are calcification. This is how chronic pancreatitis looks. Okay, in this, you are not clearly visualizing the atrophy of the pancreas, but what you can visualize is there is echogenic foci, multiple white dots. These are all calcification. Now, coming to this next slide, you can see calcification clearly on both the sides, and along the calcification, you can see a dilated duct, pancreatic duct, as well as you can see that this is a gastric stomach bowl, and you can see that the distance between the duct and the stomach is the parenchyma is very thinned out. So this is the atrophy of the pancreas also is taking place, and there's also a dilated duct. Similar images here also. We are not appreciating the whole of the parenchyma. That means it's atrophic of the pancreas as well as a dilated duct. Again, I'm repeating the image with slide with the same findings. We can see a dilated duct with intraductal calculi. Now, this is the image I'm trying to demonstrate a pseudocyst, which is near to the head of the pancreas. This is the pancreas, the head of the pancreas. Next to that, you can see a cystic structure. Now, how do I differentiate between a cyst, a normal cyst, and a pseudocyst? So, in ultrasound, the cyst will be having clear fluid. But if you can see it on the left-hand side, the image, within this cyst, you can see within it, you can see a dot structures. There's like, we call it a debris, internal debris. So with this, we can say clearly, and the history as well as other associated findings. Associated findings, which I said is chronic pancreatitis finding, that is calcification as well as atrophy. We can confirm ourselves that this is a pseudocyst. Okay. Now, early changes of chronic pancreatitis, we do a better endoscopic ultrasound. As we perform this regularly day in and day out in our hospital, it's a very good for early changes. Okay, after that, we don't need to do it. And endoscopic ultrasound is more advanced than a transabdominal sonography as well as plain CTs. Why? Because we can see subtle changes. When I tell subtle changes, it means slight changes also can be appreciated by endoscopic ultrasound. Okay. So normal chronic pancreas, normal pancreas in endoscopic ultrasound is homogeneous appearance and slightly hyperechoic to liver, that is salt and pepper appearance. But what happens when in a patient of chronic pancreatitis? In chronic pancreatitis, we can see there's a lot of cystic changes, there's a fibrotic strands, and this all are showing fibrosis. So it is much more superior than transabdominal and CT in early diagnosis. So what I've showed in this color plate is I'm just demonstrating how the endoscopic tube is passed. The scope is passed up to the stomach level, and the probe is passed, and you can see the sonographic probe visualizing the pancreas with the cyst. This is how we visualize the pancreas as well as the CBD as well as the biliary radicals by passing the probe. And this is again the ultrasound image required by endoscopic ultrasound. So if you look at the left-hand side, this is the pancreas where the arrow is pointing out. This is the pancreas. But along with that, you can see these white lines. Okay, these are in our language we call it echogenic strands. But for your basic language, it is white strands to make it much more better understanding. These white lines. This is all suggestive of fibrosis. On the right-hand side, you can see clearly visualize the duct, this dilated duct. Now, to jump to the most advanced of our imaging, that is cross-sectional imaging, that is CT of the pancreas. What I put as the first slide to make you understand how does the CT look in the normal plain CT. Right, our language in radiology, my left side is the right side of the image and my left side is the right side of the of my hand. So the liver, you can see where the pointer is pointing out. You can see the pancreatic body and the pancreatic tail. It's in the retroperitoneal structure, and the spleen on the left hypochondria. Now, what do you see in CT? Same findings in ultrasound, but better visualization. That's atrophy of pancreas, dilatation of intrapancreatic duct, calcification, and pseudocyst. So, calcified chronic pancreatitis. Now, on the left-hand corner, upper corner, you can see the white, shiny dots. These are calcification. Okay. In all the four images, you can see multiple calcifications. Okay. So, multiple nodal calcifications we can see. On the right hand upper corner, where the pointer is pointing out, you can see a tubular dark structure. This is a dilated main pancreatic duct. Okay. And we can see also in the left upper corner, that is the head is appearing slightly bulky. If you remember, sir was taking the slides towards the end where a mass is formed, inflammatory mass because of chronic pancreatitis. This is how it looks. In this case, there's no atrophy here. Instead of that, it is bulky. Like if you look at a lower corner where the pointer is pointing, this is like forming a mass there. Okay. Rest of the body is atrophic. Again, similar images where I'm demonstrating intraductal calci, where my pointer is pointing out the second row in between. Okay, this is the intraductal calci. Now, what are the complications which we see? We see a pancreatic cirrhosis, we see biliary obstruction, we see venous thrombosis, we see pseudoaneurysm, as well as fistula. Now, again, I'm just demonstrating the complications. How does the image looks like? I have demonstrated how the cirrhosis looks in a ultrasound. Now, how does the cirrhosis appear in a CT? In CT also same thing. You can see a unilocular cyst, thick walled, closely abutting the pancreas. Along with that, you can see pancreatic calcification, dilated pancreas, as well as atrophy of pancreas. So that way we can confirm that our finding is pseudocyst. Now, this is just demonstrating you multiple pseudocysts in this case. Now, these are pseudocysts where I'm pointing out in all the 4 slides, you can see pseudocysts. Now, what do you think this is, where the pointer is? Around the liver and everything. That is nothing other than ascites. Okay? All right. Now, this is an interesting slide because one of the most rare complications and most important complications, it's an acute condition where intervention is required from the gastroenterologist as well as the radiologist. Both the people will be working in hand to treat this condition. In my left hand, you can see that it's a mass near the tail of the pancreas. Okay, and this is a contrast image. Let me repeat that. This is a contrast. How do you know this is a contrast image? Can you see this aorta and IVC? This in a usual plain image, it is dark. But when you say it is white here, this is contrast. Okay, so this is just to lighten your thoughts, to make it easier in simple layman language. That's why I'm using the word white. Okay, so that you can understand this is a contrast enhanced CT. So you can see a mass near to the tail of the pancreas, which is dark. But in the center of the mass, you can see something white. Okay, so this was not white in a plain CT. It was dark. But after giving contrast, this was enhancing. Okay, you can see it here. So when you see a mass with an enhancement on the contrast, we have to think in terms of pseudoaneurysm. So what is pseudoaneurysm? So pseudoaneurysm is nothing other than when you have chronic pancreatitis or a pancreatitis condition where the pancreatic enzyme is attacking the wall of the blood vessel. You know, inside the pancreas, you know the splenic artery, splenic vein, all goes through that. It erodes the vessel wall. So the vessel has 3 layers, adventitious, medium, and intimal layer. The outermost layer is eroded and it forms an aneurysmal dilatation, it forms a bulbous nature. And that bulbous nature forms a pseudoaneurysm. That's why this is a name given as pseudoaneurysm. It's not a true aneurysm, it's a false aneurysm. So you have a bulbous nature here and you have an enhancement in central part. So you have to think of acute condition, that is splenic artery pseudoaneurysm. And you can also see within the spleen, where my arrow is pointing on the right side image, you can see there is also enhancement there. So that is also a pseudoaneurysm in the vessel. Okay. Now here again I'm demonstrating a pseudoaneurysm, but in a different vessel, not in the splenic artery. This is how the plain image looks like. On contrast, you can see enhancement where my pointer is. That's the gastroduodenal artery. Along with the and the reformatted image, you can see the gastroduodenal artery, and there's a bulb, a aneurysmal dilatation here, which looks like a bulb, a ballooned structure. That is pseudoaneurysm of gastroduodenal artery. Now, this is a very rare complication, a very interesting case. This is a pancreatico-pleural fistula. So what do you mean by pancreatico-pleural fistula? That means there is a communication, there is a tubular communication with the pancreas to the pleural cavity. Now focus on this image. This is the liver, this is the stomach, this is where the pointer is, this is the pancreas. You can see a communication, a dilated duct, and you can see it tracking all the way into this particular area. Above the liver comes the heart. Behind the heart comes the lungs. But you can see this particular area where the pointer is, this is completely effusion. And you can see a communication between the pancreas and the effusion. This is pancreatico-pleural fistula. Okay, rarely seen in chronic pancreatitis, but it's a very important complication. So how do we come to a diagnosis of this? One is CT. But other than that, we also have to take aspiration, send it for our lab values, see what is it coming out, whether you're getting pancreatic enzymes or not. Now, main important question is, I have discussed ultrasound, the X-ray, as well as the CT. So is it necessary to break your heads and write MRI? Don't know about MRI. Okay, as an intern, you might not, you want to pass a final exam, it's not much needed. But if you want to get your PG entrance, yeah, you need to know a little bit about MRI. So the most important thing, how does MRI help more than CT? There are only three things which I'm highlighting here. That is the main pancreatic duct abnormalities, which sir has already told, the biliary strictures. MRCP is important. The main pancreatic duct lithiasis, like cholesterol crystals, MRCP is again important. And now, which is not well visualized in CT, we can do it better in MRI, is that to see communication between the pseudocyst and the main pancreatic MRCP is more important. Okay. Now, these are a few images which I'll show in MRI. These are different MRI images. Okay. You just concentrate on the lowermost where the pointer is. This is MRCP. You can see the dilated duct. Okay. As well as you can see narrowing. This is dilated pancreatic duct. What you see here is stomach. Okay. Which you can see the Rugal pattern. You don't need to focus on that. Or MRCP is focused on biliary radicals and CVD, and that's all we need to focus on. Okay, you can see narrowing at area, segmental narrowing. Okay, as well as within this duct, at the topmost, we can see within the duct few dark foci. This is nothing other than lithiasis. Okay, now in this particular slide, I just tried to show you comparison between CT, MR, and MRCP. Okay. In CT also we can see a pseudocyst in the region of pancreas head. In MRCP also we can see a cyst in the pancreatic head. You can see in MRI you can see a cyst. In MRI this brightens up. Okay, this becomes brighter, like a tube light bright. It becomes brighter, and you can see it's white in color. This is just demonstrating a cyst in front, pseudocyst. Okay. Again the same MRCP images where I can show you, demonstrate you the pancreatic duct. You can see a something dark inside within the duct, that is a calculate, and you can see mild narrowing at places. This is strictures. Okay. Now this is again MRCP which I'm showing you, the lower slide. You can see the stomach, like I told you before, the Rugal patterns that I'm pointing out, and posterior stomach you can see a duct, a cyst, which is brightens up. Okay, this is displacing the stomach anteriorly. This is nothing other than pseudocyst. Okay. Next topic is biliary structure. One of the common things which biliary structure, why am I talking about this, is you'll come to know later. Malignant structure is there and benign structure is there. So what do you mean by structure? Structure is nothing than subnormal narrow. So what is the cause of malignant structure? What is our topic is, since it's dealing with pancreas, let's focus on pancreatic head of adenocarcinoma. And benign causes, one of the benign causes, chronic pancreatitis. Okay, our radiographic features are just focus on the benign features and malignant features. In benign features, there's nothing than smooth and tapered margins. The malignant features is irregular shoulder margins and thickening and enhancement. So this is again what I'm demonstrating is a coronal section of the CT image of the CBD, not a pancreatic CBD, in which I'm showing you this is the CBD cutoff and there's a marked dilatation of intrahepatic biliary radix. So this is either malignant or the benign, but we are not clearly visualizing the biliary, the distal end of the CBD. So most likely this has to be a malignant. Okay. Now, very important topic which Sir ended last time was mass forming chronic pancreatitis, which is also seen is quite challenging when it comes to radiologists, because we need to know how to treat this patient. Are we treating a mass forming chronic pancreatitis or are we going to treat a malignancy? Okay. So how does imaging help in it? Okay. So in CT, it appears there are few signs which is important. But the most important sign is this one, which my pointer is pointing out, duct penetrating sign. I'll demonstrate it in the image so you'll understand it better. Okay, rest all is the adjacent findings of chronic pancreatitis. Okay, now concentrate on images. You can see there is a dilatation of biliary radicals in the first slide, and then you can see the dilatation of main pancreatic duct. You can see there is some intraductal cataly. Okay. Now focus on the last image. Now you have a mass here. Okay, and you are not sure whether this is a malignancy or whether this is a chronic pancreatitis. So what is the, like I said, duct penetrating sign? Now, if it is a mass, okay, you cannot see the common bile duct, as well as you will not be able to appreciate the pancreatic duct. But in case of chronic pancreatitis, you can visualize the duct, but it will be narrowed by the mass. And you can, in this coronal image, you can see this where the pointer is. You can see the duct going all the way up to the duodenum, opening into the ampulla of water. Okay, this is how it goes. So in case of malignancy, you will not be able to see this mass. That's the first point. The second point is you have to remember is these are vessels. You see this tubular structures, these vessels. Okay, it can be artery, it can be vein. Regardless of that, if it is a mass, this mass, if it is a malignancy, this malignancy will be infiltrating into this vessel. Okay, so that is the most important two features you need to understand in how to differentiate by imaging if it is a mass forming chronic pancreatitis or adenocarcinoma of pancreatic head. Okay, now this is a small summary where I've downloaded from a journal, which is what you need to remember how to differentiate in imaging mass forming pancreatitis as well as adenocarcinoma, pancreatic duct adenocarcinoma. Let's only focus on few things, that is duct penetrating sign, double duct sign, SMA to SMA ratio, vessel encasement. Okay, duct penetrating sign is what I told you for benign cases where you can trace the holes of the duct. Okay, and double duct sign, where if it is adenocarcinoma, it is infiltrating the duct, the CBD as well as the pancreatic duct. Because of this infiltration, you can see a dilated CBD as well as a dilated pancreatic duct. This is a characteristics of a pancreatic duct adenocarcinoma. Now, and lastly, a vessel encasement or a deformity, that means nothing else. It is infiltration in those vessels. Okay. In this, I am trying to demonstrate a benign cause of the pancreatic head mass. Okay, that is, it's not adenocarcinoma. We can see a dilated duct. all the way up to here. But see this particular image where it's circled. You can see a calcification that's in the CBD, and you can see around it also a small duct has been narrowed. So this is how a mass forming chronic pancreatitis looks like. Okay. Now in this particular image, this is a plain CT, like I told you before, and this is enhancement CT, enhancing CT. Okay, contrast enhancement. You can see a mass here. Okay, and you can see this is a vessel where my pointer is. Okay, and in that you can see there is encasement of that vessel. So most likely this is a pancreatic adenocarcinoma. Now why this is all important, why am I telling this all, is because the surgical management changes. Like sir told about phrase surgery, if you remember the slides, as well as he has told about a Whipple surgery. So both are important, and surgical management of this diagnosis is very important. Now I will talk about a few varieties of the chronic pancreatitis. That is autoimmune pancreatitis and group pancreatitis. Autoimmune pancreatitis is a rare form of chronic pancreatitis. It is IgG4 related diseases, mostly related with Sjogren's syndrome and all. It is not acute pancreatitis, it is a form of chronic pancreatitis. Okay, so you need to get all the tests done for IgG4, and you can see a smooth, diffuse pancreatitis. It's not like focal or multifocal in acute pancreatitis or chronic pancreatitis. You will not see calcification and all. And this is, look, you can see a smooth enlargement of the pancreas. Okay, if you remember the anatomy, you can see pancreas having slight lobulation. We are having a loss of lobulation. Instead of that, you're seeing a smooth enlargement of the pancreas. And this has a particular term here. This is called a sausage digit. Okay, it's a radiological names which we give for our spotters in radiology. Okay. This is a groove pancreatitis. This is a type of pancreatitis, chronic pancreatitis. Now, what do you mean by groove? You know how the pancreas head lies. So, pancreas head and duodenal groove lies closely abutting each other. So, at the groove, that is a pancreatic or duodenal groove. At that area, you can see inflammatory changes taking place. Now, why this is taking place is because the accessory duct obstruction takes place there. Because of that, pancreatitis takes place. Okay, so you just focus on the left hand lower corner slide. This is the pancreatic head. This is the duodenum. Between this, you can see a mass like dark area. This is nothing other than a pancreatico-duodenal pancreatitis. Okay, and you can see a dilated duct, tubular structure, where I'm pointing out to you in the arrow. All right. So to summarize all this, for your repeating it again, what you need to know is for your surgical practical exam, you just have to focus on how does the X-ray of chronic pancreatitis look. Okay, for your PG entrance exam, yes, you need to know importance of what MRI findings as well as the CT findings and the pseudocysts and pseudolymphocytes. Thank you.
That was extremely well done. That's extremely well done, starting from ultrasound of pancreas to CT MRI, pancreatic cysts, pseudoaneurysms, pancreatic pleural fistula. Excellent, well done. So we come to an MCQ of pancreas. This is rapid fire rounds, and rules of the game will be explained by Dr. Abraham Matthew. Dr. Abraham Matthew did his MBBS from the Trivandrum Medical College and MS General Surgery from Bellary Medical College. His special interest is working in mission hospitals, laparoscopic surgery, head and neck surgery, and he is now working in the capacity of associate professor in the Department of Surgery at Believers Medical College. So students, please answer in the chat box within few seconds, and sir will show how these rules are. So handing over the mic to Associate Professor Dr. Abraham Matthew.
Thank you, madam. So it is not chat box quiz this time. This is a new venture into an online quiz platform, which is called the Kahoot. And I have already given instructions to the exam going batch, and I think it has been handed over to the junior batches. So I will just give you the instructions to the quiz. Ideally, you should have two screens for participating. One to see the answer, to see the question, and the second is to click the answer. So you need 2 screens. And in each of your device, one of your device, you download the Kahoot app from the Google or from the Android Play Store. Then once you log in, you can enter the game pin which is shared on screen. That is 8854633. So once you enter the game pin, you can use to log in with a nickname. As you can see on the screen now, many students of you have been logged in, and then once all of you have logged in, I have given option up to 200 students to log in, and once all of you have logged in, I will click on the start which is there here, and once you are logged in, I will give 2 minutes for that. Then once I press the start button, you will see the question on the screen, and after each question, you can click the answer on your second screen. And after you click the answer, after each question, the marks of the top 5 students will be shown after each question, and there is a time limit per question, 30 seconds to 60 seconds based on the difficulty level. And between questions, there is a pause until I click the next one. The next question will not appear, and then I can do some discussion between questions also. So I will give you 2 more minutes. Up to 200 students, even junior batch, can log in, and it will be an exciting time to go to Kahoot. And I have prepared 18 questions. Some are multi-answer questions that will be said before the question, which is multi-answer or single answer. Some are true and false questions. Some are image questions. Figure is given. You will have to identify in the figure. And I hope you are ready. I think still the time is taken. 75 students only have logged in. I have given the slot for 200 students. So hope you all enjoy the quiz. And if there are no more students to log in, I will start shortly. Okay, ma'am is saying to start, so I shall start. So you will have to see on your screen. So that is the first question. The body of pancreas is overlying which vertebral body? You have got 10 seconds remaining. Is it T12? Is it L1? Is it L2 or L3? So 22 people have answered. Few more seconds remaining. Time is going. All of you can answer the simple question. And now this is the bar diagram showing only 16 of you have got it correct, and that is the L1 vertebrae. So basic anatomy questions you should not forget. Shall we go on to the next quiz? I'll put some music. This is the scoreboard. Okay, Sumesh is leading. So we'll go to the second question. The most common hyperlipidemia causing pancreatitis involves LDL, HDL, VLDL, or triglycerides. So be fast in your clicking. Only 13 seconds left. So easy questions. The fastest answer will get the maximum marks. Yes, so the time is over, and definitely it is an easy question. 35 of you have got the right answer, and that is triglyceridemia or hypertriglyceridemia can cause acute pancreatitis. So let's see the scoreboard. Sumesh is leading. Yes, that, and now it's a Payasam is on. Nice names you have created. Shall we go to the next question? So this is a puzzle round. It's a double points question. You have to arrange the 4 choices in the descending order of common etiology for chronic pancreatitis. The commonest first and the least, that is the rarest last. So you have got little extra time this time, 60 seconds. Now think carefully and make the choices in your phone. I can see only 16 people have answered this question, slightly higher difficulty. So take your time. Those who have studied the subject well will be able to answer this question. Yes, last 10 seconds. Last 10 seconds. 5. Yes. So good. So the correct order is alcohol, gallbladder stone, hyperparathyroidism, and pancreatic divisum. So it shows that 54% of you have got the correct answer. So the scoreboard changes and keep on trying. For the next question, the fourth question, true and false. Easy question. So true and false, you have got just 20 seconds. Pancreatic divisum is the commonest congenital cause of recurrent pancreatitis. True or false? Less time, easy question. For the easy question, less time. Yes, time's up. 39 of you have got the answer correctly. Yes, pancreatic divisum is the commonest. Scoreboard, Nikhil R is leading. Shall we go to the next question? Fifth question. The sign shown in the photo below of a patient with acute pancreatitis is called A. Balance sign, B. Fog sign, C. Gray Turner sign, D. Colored sign. So easy question. Those who have read the subject will get the answer. And last time is out. Yes. Only 7 of you have got the correct answer. So this is an important question. All of you not the point. Let's go to the next one. Before that, Gray Turner sign is for the flanks and colored sign is for the umbilicus. Balance sign is totally out of topic using splenic trauma. Scoreboard, Lakshmi G is leading. Shall we go to the next question? 6 of 6 remaining. Choose all of the factors that can cause pancreatitis. So this is multiple choice, multiple answer question. You have to choose the correct answers. So given more time for that because it's multi-answer. Choose all the factors that can cause pancreatitis. I hope you are enjoying the quiz. Look at the answers very carefully. Don't make mistakes. So last 3 seconds to go, and then time's out. Yes, so you have got some answers here. Many of you have chosen hyperglycemia, hypercalcemia, mumps and roundworm is the answer. So 7th question, double points. Dash is a consequence of acute pancreatitis. Carefully read the answers, the double points for this. So you have to carefully read what of the following is a consequence of acute pancreatitis. Hypoglycemia, hypercalcemia, lowering of LDH, decrease in hematocrit. Who is, remember Ransom's criteria. Yes, last 3 seconds to go. Yes. Up. Yes, the answer is decrease in hematocrit. There is always increase in hematocrit. LDH increases. Hypercalcemia can cause pancreatitis. So scoreboard, Lakshmi G is leading. 8th question, true or false? In the management of acute pancreatitis, it is better to keep patient nil by mouth for a longer period. Is it a true statement or is it a false statement? You have got 10 more seconds to answer. Yes, so the answer is false. Early enteral feeding is beneficial in the treatment of acute pancreatitis. Yes, scoreboard. Lakshmi is bleeding. Shall we go to next 9th question? The most important step in treating acute hemorrhagic pancreatitis. So acute hemorrhagic pancreatitis is an important. So you have got 4 choices. Which is the most important of these 4 choices? As you can see, all the 4 choices are important, but which is the most important? You've got 10 seconds remaining. So kindly remember what you have studied, which will you give as the most important in the choices given. So the answer is aggressive fluid resuscitation of up to 200 to 300 ml per hour you should give. That is the most important. Antibiotics have no role in the initial management. Oxygen should be given. CT scan only if the patient is stable, not in the initial period. So as a scoreboard, still Lakshmi is leading. Shall we go on to the next question? 10th question. This is a multi-select polling, so you don't have, there's no points for this question. It's a bonus question, just for your knowledge. The following are the mechanisms of tropical pancreatitis, which will be dealt in detail by sir. Now you can give your answer here if you remember what you have studied. So as we are doing the quiz program, now we can see, yes, cyanogen glycoside in tapioca, hydrocarbon release from kerosene lamps. These are very important etiological factors. It's given in Bailey. Then we have got the SPINK1 gene mutation and CFTR gene mutation is in other causes of pancreatitis. 11th question, chain of lake appearance. Very favorite question, chain of lake appearance in chronic pancreatitis. But where is it seen? You have got the X-ray abdomen, you have got the CT abdomen, you have got the ERCP, and you have got the MRCP. So for those who are doubting, the clue is it has not been mentioned today. Yes, so the answer is ERCP. It is done. It's an invasive procedure which is done, and the dye is injected, and you can see the multiple dilated ducts with the intervening stenosis. So again, Lakshmi ji is the topping. We can continue. The 12th question, multi-select. That is many right answers. What is the triad of chronic pancreatitis? So this triad is not commonly seen in the early stages. It is seen in the late stages, and it has been already dealt with by Dr. Sujit. The classical triad of chronic pancreatitis. We have got 10 seconds remaining to get the answer. The triad of chronic pancreatitis includes so calcification, steatorrhea, and diabetes mellitus occurs in the late.
Amma.
Yes, so that's so the other eye is leading. Shall we go to the next question? Okay. 13th question, double points, tough question. Very tough question.
Amma.
Only exam going students should answer.
Go ahead.
The venom of dash can cause pancreatitis. The clue is in the photo given, but you have to tell the scientific name. Yes, the clue is, of course, it is the venom of scorpion that can cause the pancreatitis. But which among the choices is scorpion? That is the question. What is it, madam? Yes, tough question. Yes, let me see. Yeah, 16 of you have got Tithias trinitatus. That is the scientific name of scorpion. The others, Naga is cobra. Solenopsis geminata is the red fire ant, and Apis mellifera is nothing but our honeybee. Okay, that's a good question. Next, let's see who is getting. Anne is leading. Yes, 14th question. What does the figure below show? So this is a figure you have seen. Figure taken from your favorite book. So as you can see, what does this figure below show? So obviously it's the duodenum pancreatic area. So what does it show? Yes, This is a normal pancreatic ducts that has been shown. And I think only 6 of you have got it right. But the next question is a similar figure, which you might all get right. So what is this figure? The second figure below show. So here, very closely related to the previous question, but here there is a difference. Yes, time's up. It is the pancreatic division. There is a separate duct which is a common cause of pancreatitis. Yes, I will go to the 16th question. Multi-select question. Atlanta classification of acute pancreatitis. If you have not heard of it, it's in your Bayesian textbook, favorite textbook of surgery, if you have read it. Classifies acute pancreatitis into mild, moderate, moderately severe, and severe. Out of this, which is the wrong answer, or choose all correct answers. Yes, so mild, moderately severe, and severe is the answer. There is no moderate acute pancreatitis in the classification. Yes, scoreboard again, Lakshmi ji is again raised up. Yes, second last question again, multi-select. A patient with past history of acute pancreatitis presents with a mass in the epigastrium could be. So with a past history of pancreatitis, the patient can present mass in the abdomen, epigastrium. So which are all the possible diagnosis that can come in this situation?
If it's a lady, she can be pregnant.
That is a very good answer, ma'am. Ma'am is giving a very distractor. Yes, ma'am, you're right. So I given some more extra time for this. There
You
is
have not written acute intestinal obstruction, stricture of
yes, very good, madam. I have 4 choices only. To make, if I had more choices, I would have included that, madam.
intestinal.
Yes.
Intestinal obstruction, you have not written.
Yes, ma'am. Yes, so the last 10 seconds, 53 only have answered. Keep going, keep trying. Yes, so the answer is wrong. Yes, wall of necrosis, pancreatic cirrhosis, splenic artery aneurysms can be presenting with mass. Acute pancreatic fluid collection occurs in the period of the first admission. That's why it may be a mass, but it is found only in the first admission. The rest 3 occurs later on. So that is Lakshmi is still leading. And the last question, the easy question for you, if you have heard these lectures carefully. So the figure below represents the phrase procedure. Is it true or false? So remember what Dr. Sujit has said regarding the treatment of chronic pancreatitis.
It can be either Whipple's or Baker first.
It can be resectional or it can be diversional. So it's sad to see that 13 of you have got it wrong. It is a true one. It is also called longitudinal pancreatico jejunostomy with head coring. This is the phrase procedure. Don't forget this. This is an important question. So let us see the big score. The podium. Who are the winning? Who are the winners? So Sneha has got the third, and then we have got Sriraj, and then the winner is big applause to you. So that's good. So all of you have well participated. Hope you have enjoyed the quiz. And if you want the questions, we can share it.
Yes, sir. Thank you,
You
sir.
can give your feedback. Okay, hand over to Madam.
Can you stop, sir? Okay.
Yes.
So let us conclude and wind up this wonderful academic session. Thanks to all the speakers for enlightening us. Thanks for the wonderful quiz, sir. So I thank, I really appreciate Dr. Lakshmi ji for this answering. She got 100 points ahead of all of the other students. Sriraj and Sneha also for standing second and third. And Adira and Anjali, they also answered very well. They were fourth and fifth and sixth. Okay, Nipin, Jubin, Nikhil, Vadi, Sam, Theo, Parvati, you all participated also, and so many others participated. I think all of you should be appreciated for participating. Big hand for all of you. And Dr. Sujit Philip, he really explained very well. Chronic calcific pancreatitis or tropical pancreatitis, which is seen in Kerala. And Dr. Danny Jones Titus, his class on the imaging of the pancreas was extremely fantastic with so many figures. Dr. Abraham Matthew, really, sir, thank you so much for the fascinating quiz contest. It was really a very exciting session, and hope all the students have got excellent take-home messages from today's session. Next academic session will be on Thursday, again on next Saturday. So meet you next Thursday at 3:30 p.m. with yet another interdepartmental academic session. So wish you a wonderful weekend. Till then, stay home, stay safe. Bye.